Good afternoon and welcome to Ashgrove TV. This is the first of our broadcasts and we're hoping that you're going to enjoy it. We've actually been broadcasting live from this TV studio for about 10 years now in Higham, but broadcasting just to osteopaths, and we realised that actually we wanted Ashgrove to have a part with the TV as well. So here we are. We're going to be talking about shoulders. It's going to be me. I'm Claire Short, one of the clinic directors, and Stephen Bruce, my husband. And Stephen, tell us, shoulders are quite topical at the moment, aren't they?
Well, hang on. So you're an osteopath and you're the clinic director. I feel quite offended,
Do
actually.
you now? Oh, well.
I am also an osteopath and I'm also one of the clinic directors. And yes, you're absolutely right. Shoulders are topical because for anybody who's interested in the cricket... Anyone who's interested in the cricket, one of the very most exciting tests in recent years, England had to play three quarters of it without their main fast bowler because he fell over when he was fielding. And I don't know what he did to his shoulder, but it looked as though he possibly dislocated or subluxated his shoulder. But it meant that in the final few balls of the game, he had to bat with his arm in a sling underneath his jumper, so he was there basically as a token batsman. Unfortunately, didn't have to face a ball. So shoulders, yes, shoulders are topical. They're also common, aren't they?
Very, very common.
I don't mean shoulders are common, I mean shoulder problems are common. Shoulders are fairly common as well.
Yeah, fairly common. But shoulder injuries, you're right, they are really common. And we see many, many of them in the clinic. But the thing that I find fascinating is there's such a breadth of ways of injuring your shoulder, and not just the type of injury, but the damage you cause to the shoulder. Yeah,
and they can cause a lot of pain. But I suppose what people are really concerned about is the loss of function in the shoulder as well.
Yeah.
And then, of course, they'll turn to Dr. Google and there'll be all sorts of scary stories on Dr. Google telling you what might have happened to your shoulder, when, of course, it might not even be your shoulder that's the problem in the first place. It could be a variety of different things. And I suppose what we want to do today is to, first of all, emphasise the importance of getting a proper diagnosis, an accurate diagnosis of what's going wrong, because you can't fix a shoulder, you can't treat a shoulder yourself or have someone else do it unless you know what's causing the problem. But also dispel all those concerns that people have got about, the horrible things that could go wrong with their shoulder.
And so often people will come into us and say, I've got frozen shoulder, just because they can't move their shoulder very well, when it could be osteoarthritis, it could be a problem with the little squishy gel things called bursa, or it could be a rotator cuff problem, but quite often...
There's a really good point you made there is that people are often told that they have got a frozen shoulder, and they could be told that by medical professionals. And I'm not wishing to put down any particular medical professionals, but some people are more expert at musculoskeletal injuries, i.e. the anatomy and physiology that we osteopaths deal with. Some are more expert in those than others, and it's very easy just to use the term frozen shoulder as a general term for something wrong with your shoulder.
Yeah.
I mean, it is a very specific condition, isn't it, which you're about to describe to me.
That wasn't part of the plan. Yes, so frozen shoulder is quite a nasty condition because it can come on very, very slowly. So you don't think it's anything too serious, but progressively you get less and less movement in your shoulder. So some of the patients we've seen have come in only able to move about this far, haven't they? And it has a pattern to it. So you have the freezing stage, then the stage where it's frozen, which is where you can't move it, and then the thawing phase. So usually it can get better by itself within... It's about 2 years, 18 months, 2 years, isn't it?
Well, people have often said that in the past, but the more recent studies have said, all that pain you've experienced over the 2 years, you think it's all gone, but you haven't got back the full function that you had beforehand. You've just got, it's improved from where you were during the frozen shoulder phase. Yeah. What you didn't say is, of course, there's no obvious cause for frozen shoulder. True. It just happens. I think it's more prevalent in women than it is in men, more prevalent over 50 than below, but anyone can get it. And it is a seriously, seriously nasty problem. It's going to stop you from washing your hair. It's going to stop, not me, but you, from undoing your bra strap because you can't get your hand round behind your back. All sorts of little things, which you're going to do every day regardless of the injury, which is one of the bigger problems with shoulders, isn't it? People will say, oh, well, if you've injured something, well, rest it. you can't rest your shoulder. It's almost impossible because instinctively you'll reach for something, or in the shower you'll try to brush your hair, whatever it might be. So it's very hard to rest the shoulder completely. So
That's very true.
Are there techniques? We do have techniques, don't we, to address a true frozen shoulder, which are shown to be more effective than other physical therapies. What would the surgeons do for frozen shoulder, though?
They would do a manipulation under general anaesthetic, which basically means lifting your shoulder to as far as it will go under general anaesthetic, and then going bam, all the way up.
Essentially, what they're going to be doing is they're going to be ripping the tissue which is holding the shoulder in place. And there are questionable statistics about the success rate of manipulation under anaesthetic.
Sometimes it works really, really well, doesn't it?
I think in most cases it will work, but the evidence suggests that it's actually no better than just doing physical therapy, because you need just as much physical therapy afterwards to restore function to the muscles as you would have done otherwise. There is also a serious risk of fracturing the upper bone of the arm, the humerus, isn't there? Because
I didn't know that.
Yeah, they're putting a hell of a lot of force through this. It's an extraordinary amount of force, both in rotation outwards as well as lifting the shoulder. So yeah, it does come with risks, and not only that, but there's the risk of the general anaesthetic as well. So you can have that done. You've then got a long period of physiotherapy to make it recover. Physical therapy. It could be a physiotherapist, or it could be an osteopath, or someone similar.
But we knew all about this, didn't we? And so we very carefully organised for the guy who does the leading technique in frozen shoulder to fly here from Israel to run courses for us and other osteopaths, but partly because we both wanted to learn the technique.
Yeah, so we've both done those courses, and we've got
Jason Sheridan as well.
So Jason in the clinic, he's done that course as well, and Jason is very, very good on shoulders, isn't he? The
nice thing about Jay is he also uses the laser machine, so he can use the Neil Asher technique and the laser machine, so you've got kind of, you're attacking it from all different areas.
Yeah, so just putting that one to bed, well, actually putting it to bed, that's one of the big things about frozen shoulder, isn't it? The pain is unbelievable at night for many people. It stops people sleeping, and it's just hideous.
And I think
we actually had a question's just come in actually saying, why does my shoulder hurt at night, particularly when I lie on it?
I was just going to say that shoulder pain is usually worse at night because you're either compressing it as you lie on your side, or you're tugging it forward as you're lying on your side, or if you lie on your other side, the top arm then drops forward. And if you lie on your back, as one of my patients the other day experiences, the shoulders drop back, and that can tug on it. So how you experience night pain with a shoulder problem really depends on where the injury is, whether it's front, side or back. But with frozen shoulder, the position is irrelevant. You just have nagging pain all night, don't you? You just cannot get comfortable.
And I suppose people might be wondering what it is that's causing that pain with the frozen shoulder in the first place, or the restriction of movement and so on. And like we said, it is very unclear what it is that's causing it all. But if we take our little model shoulder here, I mean, all around the shoulder, we've got that very tight fibrous capsule holding the whole thing together and holding in the fluid that sort of lubricates the joint, if you like. And that capsule tightens up, and inflammation comes up the biceps tendon, so up the front of the arm, and goes into the capsule. So you've got tightening of the capsule, you've got inflammation, all of those things causing restriction of movement and pain. But we can, no one's going to pretend no one can fix a frozen shoulder instantly. And you might get symptomatic relief from corticosteroids, perhaps, but even that's not guaranteed. But it's a long-term fix, but we can do it with physical therapy without the need for brutal surgery or anything like that. So it's, I suppose we ought to talk, didn't we, about rotator cuff as well, because that's one of the things that everyone hears about. Lots of sportsmen will hear about it, and everyone will have some degree of knowledge about rotator cuff. Do you want to tell us what a rotator cuff is?
Yes, so I'm going to grab the model. So a rotator cuff is on the shoulder. You've got four main muscles that produce a kind of a cuff, if you like, around the shoulder, and cause it to move.
To rotate.
And to rotate.
Can you lift that up just a little bit higher
sorry.
so it can be seen a bit better? Yeah.
And it makes almost like a sling around the shoulder. It causes it to do the rotation movements. But if you strain, if you overstretch part of your shoulder, and that's the main cause of injury to rotator cuff, which is why it's so common as a sports injury. And it's
but we talk about injuries to the rotator cuff tendon, don't we? But they all blend into each other around here. There is no single tendon effectively.
I was just going to say, it's actually a really beautiful structure because of the way it all blends together. But when you're told that you've got a rotator cuff injury, it doesn't actually specify which muscle has been injured, and each one does a different job. So when it comes to doing your rehab and having treatment, we really need to know, not that it's a rotator cuff injury, which muscle is actually damaged.
Yeah. And I imagine that laser's pretty good on this, whereas particularly if it's an acute injury. Acute injury means something that's happened very recently. It's often misused in common language, but in medical terms, acute means it's recent, as opposed to chronic, which is long-term. But laser's very good on chronic, also on acute injuries, isn't it?
Absolutely brilliant, yeah. All of I think we've got 5 practitioners now using the laser machine, and it's really great for tendon injuries, ligament injuries, and strains and sprains, which is why it's so popular with athletes, and also weirdly with motorcyclists.
Yeah. And one of the things about rotator cuff is that, again, it needs expert diagnosis to work out, as you said, which bit of the cuff is damaged. And there are, if you were to look in medical textbooks, it would tell you, oh, these are the tests for the rotator. Well, they're all, you've got to put them all together and use them with clinical judgment, haven't you? Because nothing is specific enough to say, yeah, right, we've got it here.
Well, that probably brings us on to scans. And normally we would say that if you've had a scan of an area, it won't necessarily tell you what's causing your pain, will it? Because you can have... Sorry, Karen.
There's a really good example of that. Is most people will heard probably of supraspinatus, the muscle which goes over the top of the shoulder blade and onto the upper arm, and they will have heard of the supraspinatus tear or supraspinatus calcification. Those are things which come up, and those things can be shown up in scans. But should we do a little demonstration here? I've got this little rubbery, stretchy, therabandy sort of thing here to represent muscle. So it'll stretch and contract like muscle will. So if you hold that end of the muscle, and it doesn't matter which end is which, that's the end attached to my shoulder blade, this is the end attached to my arm, so it can stretch like that to lift the arm. However, on this muscle...
It doesn't stretch to lift the arm, it contracts to lift the arm. It contracts
to lift the arm, thank you for the correction. But, it's not just one single item. There's lots of strips of muscle in here and lots of cells and so on. This is not an accurate representation of a muscle, it's just something I made up for the show today. But, for example, if you have a supraspinatus tear, it's got a hole in it. So there's a hole in that top strip there, which you can see with my finger poking through it. But these strips are intact. So the muscle will still stretch and contract perfectly happily. And you might have heard of a full thickness tear. Now, a full thickness tear sounds really scary. And you're thinking, crikey, a full thickness tear, how is the muscle possibly going to work with a full thickness tear? And lots of practitioners, osteopaths, chiropractors, physios, doctors, whatever, lots of them will be misled by that term, full thickness tear. But this is a full thickness tear. I can put my finger right the way through the muscle there, it goes all the way through, but the muscle still stretches and contracts.
What's a rupture, Stephen?
This is a rupture. Now the muscle won't stretch or contract, and that's going to require surgical repair in almost all cases. So if that helps to explain those different terms, then I'm pleased.
And that's where I think for shoulder injuries, I think it is important to have a scan, because you find out which of those 4 muscles is injured and what degree of injury you've got.
But it's still only a clue.
Exactly.
Because I've got some statistics, rough statistics for you here.
Here we go.
If you look at the overall population, something like 23% will have a tear of the supraspinatus muscle, the one we've just looked at there. Now, if you get up to the 50 to 60, it's something like 15% of them. If it's the 60s to 70, it's 25%, 70 to 80, it's 35%, and above 80, depending on the study, it could be 50% of people have got a tear of the supraspinatus muscle, and 2/3 of them will have no symptoms whatsoever. So just being told that you've got a tear in that muscle doesn't mean that it's the muscle that's causing your symptoms or causing the problem. It could be, and it's definitely worth an expert evaluating it to see if that is the cause of the problem. But I'm bound to have tears in my supraspinatus now. You probably got them, more common in men I think than in women, but even so, it's not guaranteed that because the MRI says that you've got a tear, that that's the cause of the pain.
The flip side to that is that if you've had some kind of sports injury and you have got sudden onset of pain from the injury, it's helpful for us with the rehab to have seen a scan to know which of the muscles is injured. And you're absolutely right that if we were to do a scan on someone who's had pain building up, I think that's more misleading with the scans. But
and you've got to bear in mind with this is a really complicated joint. Not only is it a complicated joint, it is inherently unstable because it has to move in so many different directions.
Oh, let's do the ball and socket thing.
Well, okay, but you do the ball and socket.
No, I can do it. So with a hip, you've got a socket, nice round socket, and you've got a ball, and the ball goes into the socket, moves like that. With the shoulder, your socket is like that.
Very shallow.
Really, really shallow. So the ball it's got no stability. So it's no wonder we dislocate our shoulders far more than we dislocate our hips. And that's where, if you could give my hands a hug with your hands, that's where the rotator cuff comes in, and it circles that joint to stop it from flopping out all over the place.
Yeah. So to put that in anatomical perspective on the shoulder here, this is the top of the arm. In this case, it's my right arm. So the top of the right arm, this is the ball that Claire's talking about. And as you can see here, there is a shallow, very shallow socket in there into which that ball goes. So it will go up and down and it'll rotate. Doesn't do it very well because this is only a model, obviously. And then you have the shoulder blade here with muscles under that spine on your shoulder blade, over the top of it. You've got muscles between the shoulder blade and your rib cage coming out here. And you've got one coming up from the back here as well to form that rotator cuff we were talking about. I don't want to give them all their names because it's just Latin nonsense that you're going to forget. But all those things can get injured, and all of them can be injured without any symptoms as well. But still, people are going to have problems here.
Yeah.
So I suppose we have to work out, well, is this a rotator cuff problem? Is it a frozen shoulder? What else is going to cause problems in the shoulder?
Osteoarthritis. Right. That's one of the big ones we see.
Which is going to be more common in older buggers like me, isn't it?
That's very true. Much more common in older buggers like you. And I think that people get really frightened when they're told they've got osteoarthritis. They hear the words, it's bone on bone. Yeah. And that just brings up images of, falling to pieces.
In fairness, you get more of that with the knee than you do with the shoulder, that bone on bone thing, don't you?
That's very true. Very true.
But nonetheless, it's when this lovely smooth surface in here, or the smooth surface around here, just becomes all jaggly and knobbly and it doesn't look as smooth as it ought to.
Did you just say jaggly?
Jaggly. It's a medical term.
Medical terminology. Excellent. But yes, so many people get told they've had an X-ray, they've got osteoarthritis, it's because of their age, and then they just put up with the pain. And that just makes me really sad because there's so many things you can do to get the area moving, to strengthen it, and to make that pain just go away.
There's two things we want to talk about here, aren't there? One is we are great mates with the most famous osteopath in the world, certainly in the UK, and we've run numerous courses with him. And we've both watched him on courses where someone has really limited movement with their shoulder, and he's done a very simple, incredibly simple technique, and all of a sudden full movement back in the shoulder for somebody who was told they had horrible osteoarthritis. And you've got a patient.
I've got a lovely patient. I might not be the most famous osteopath in the world, but...
You're the most famous osteopath on this stage at the moment, Claire.
Why, thank you, sir. I had a patient, this was some years ago, who had been told she had a bony spur, which means that the joint here was jaggly. Instead of being smooth, it was a bit rough. And she could move her arm up to here and then was in absolute agony. And she was absolutely convinced that there was nothing I could do.
Her bony spur, that bit of bone sticking out from wherever it shouldn't have been, that was found on X-ray.
Yes.
So if there's that picture, we know it's there. This isn't someone making it up as they go along.
Exactly, guaranteed. That bony spur was there. And so she came in and she demonstrated she could move her arm to about here. And she was quite, if I'm really honest, she was quite dismissive about osteopathy. She decided to give it a go, but she didn't really think we could do anything. So I did one treatment on her, and by the end of the treatment, she went, oh, wow. And she brought her arm down and then went out to the front and went, and of course she thought I was a miracle worker, and I hadn't done anything spectacular. I'd just done ordinary osteopathy and got the joint functioning properly. Now my theory is that she was always moving in a position where her shoulders are rolled forward. And so she was hunched forward a little bit, her neck poked out, she had a desk job.
So it's all down to posture.
It's not all down to posture, it was all down to the way she moved herself. And what I did was to help her by treating not just the shoulder, but the whole back. I got her sitting more upright, I got her shoulder functioning better. I reminded the nerves how to send the right information to the brain. And so she was functioning better. And it was incredible.
We just mentioned the word posture there, and it immediately got my hackles up, because I don't know about you, but I've seen so many patients who've been told by somebody that their posture's all wrong. Yeah. And I think probably the last thing you want to be told is, oh, your posture's wrong, you've got to do this and do that. And 90% of the time you can ignore it when people say your posture's out, because you're moving all the time. It's a bit like being told you must sit like this in a chair. Well, you don't. You sit, you move, you're keeping the body moving, and movement is far more important than trying to strain yourself into some contrived posture, isn't it?
Yeah, instead of sitting like this at a desk, if you sat like that for a bit, then got up and walked around, your body would be so much happier.
And this is really, it's a topic for another day, isn't it? I remember the days when people were saying, though, that you should sit on a Swiss ball. When you sit on a Swiss ball all day, you'll be knackered and you'll be in pain. Do it for 10 minutes or something, then that's fine, and move back to a different chair. But yeah. So back to shoulders. What are we going to talk about now on shoulders? Well, one of the questions that came in was all about, I can't see, where's it gone now? Where is the pain coming from? If they had a scan, they've had an X-ray, there's nothing there, but the shoulder still aches.
This is such a good question. The fascinating thing about the body is that we know everything's connected, because if it wasn't, my feet could be over there and my head could be over there. But we really forget when we're thinking about injuries that the whole body is connected. And you can fairly often, you'll see that anybody with a shoulder problem will have tightness through their neck, tightness through your ribs. Your ribs aren't just around here, they're right up at the top as well.
Right around the top
Yeah,
as well.
right around here, underneath the collarbone. And so if any of those things are disturbed, aren't functioning properly, they can affect the shoulder, can't
and actually,
they?
Yeah, and one of the nastiest aches that you can get in the shoulder, pain you can get in the shoulder, is from the top ribs, isn't it?
Yeah.
It's really unpleasant. And usually, they don't fix instantly, but usually it's a relatively quick fix with ribs, isn't it? You can...
It's quick, but I always think of them as the drama queens of the body. When you're working
Takes
on an
one
area...
to know one.
When you're working on the body, generally, most people's bodies say, oh, okay, you're trying to help, let's move on. Yeah, obviously, they don't really talk, but there's a sense of the body cooperating with you. When you're working on a rib, the rib says, I just can't do it, I can't do it, woe is me. They're really antsy. So, yeah, it's fairly quick to treat them, but they're not happy customers.
Yeah. One of the things that perhaps is worth putting to bed at this point as well is this whole business of joints being out.
Oh gosh, yes.
Because it's very easy. I mean, to be honest, it's very easy when talking to you or talking to other patients in clinic to say, oh, the joint is out, I'm going to click it back into place or whatever. And that whole business, it's a restriction of movement that we're trying to fix, isn't it? Because once again, it's movement that is key to everything. And what you find is that a joint, and we're talking about ribs, but a rib, but we can feel it, but you can just feel when people breathe, one rib will rise up and it won't drop down as far as the others, or it'll be harder to move than the other ones, or it'll be just painful when you touch it. And all we're trying to do is to get that movement back into it to relieve that pain. And
Shoulders.
Sorry?
Shoulders.
Yeah, but we're talking about pain in the shoulder caused by a rib.
Yes, you're right.
And it can really feel like it's a shoulder pain because we just don't think about ribs being up there. We think of them being here.
Yeah, exactly.
Yeah. Other things that cause pain in the shoulders?
Well, I was thinking we're probably going to run out of time soon.
Yet.
Not yet. We must come to doing things that are helpful.
Okay, yeah, well, go on. We could talk about other things that cause pain in the shoulder which aren't in the shoulder, like neck, even the elbow to some extent. But
yes.
Let's leave that for another time. Talk about things that are helpful.
Okay, so one of the things that I've seen patients do is to try and do biceps curls to get strong, and also bringing their arms out to the sides and then doing twists to keep their arms strong. And I think both of those exercises can really aggravate shoulder problems. They're appropriate at the right time, but I think those are two that you've got to be really careful about. And once shoulders are over the age of about 45, I think they really don't like being forced to go up like this. They prefer if you turn your hands upwards and go like that. And again, that's not to say that you shouldn't ever go up that way, but I think if you've got an injury, you need to be aware that that might aggravate it.
Yeah, and we are talking about the injured shoulder, not the person who's perfectly healthy and in the gym and wants to improve the look of their shoulders by doing heavy weights. And
absolutely. That's a very, very good point. I'm talking about injured shoulders. Yeah. One of the things shoulders likes is drawing an egg, isn't it? I remember Simeon, the shoulder, frozen shoulder guy, expert, saying that the shoulders like doing that. So if you want to do some kind of movement to get the fluid in your shoulder moving, this is a really nice one to do, isn't it?
But also, it is better to get someone who knows about shoulders to work out what the actual problem is and prescribe the exercises. But if you're finding at home that you can't reach to the top of the cupboard to get out your tin of beans or whatever, well, one exercise could be just reach forward, try and reach a little bit higher and just keep doing this and just keep trying to increase the height, and then occasionally reach sideways as well. So you're putting it through rotation, you're also putting it through that shoulder flexion, as we would call that movement. But you're just gradually increasing the range of motion. But not to a point where it's going to be agonising. You might get a little bit of soreness at the end of the range, but you don't want to be doing something which is causing genuine pain, because that means you're possibly re-injuring whatever caused the problem in the first place. But like your lady with the bony spur, sometimes you need a physical intervention which will then overcome that problem very, very quickly, or facilitate these exercises to make it easy. Someone sent in a question saying, how long is it going to take to get better? I've got a piece of string in my pocket here. It is a hard question to answer, isn't it?
Well, I think going back to your beautiful muscle that you cut in half, it really does depend on what you've done. So if you've got a partial thickness tear, that's clearly going to need less rehab and less treatment than a full thickness tear, because you've got much more damage. Well,
I still come back to the fact that they might not heal, because they might not be the thing which is causing the symptoms. And so one thing we try to avoid with people is we've got their shoulder better and they want to go for another scan and see what the changes are. Well, you might not see any changes, and that's been proven in so many medical studies. The symptoms have gone away, the movement has returned, but go for a scan and, oh, crikey, it still looks the same as it did before. And it's just one of those, I don't call it a medical mystery, it just is one of those things in medicine, isn't it? You can get full recovery but not see any changes on a scan. Well, I suppose the answer is, will this get better on its own, or do I need treatment? Well, that's difficult to say without seeing the person in question, isn't it? Anyway, Claire, that's the first of our monthly. Are we going to do one a month for these shows? Or
we're going to do one a month. That's the aim. And we're also going to invite the other practitioners to come in and chat to everybody.
Great chance to meet all the practitioners.
Exactly. But also, each practitioner has a different speciality, and so we can cover different topics. You and I both love the shoulder, but I know there are knee fanatics in the clinic as well. So,
well, yeah. Well, of course, what we really need is the things that intrigue you. We don't want to be talking about stuff that amuses us. We need, what are you concerned about? And it need not necessarily be a joint like this. It could be any medical problem, couldn't it? And we get people coming in with things like fibromyalgia, which is a horrible affliction, and it's definitely not easy to treat. But it's not perhaps one of those things you'd associate with osteopaths. What are the other things you don't associate with osteopaths? Headaches is a really good one, isn't it? We should do a show on that.
And jaw pain. Yeah. We're definitely going to do one on jaw pain.
We're going to do one on jaw pain. Okay, well, I think we're done, aren't we?
I think that's all we've got time for. Thank you for joining us. We hope you've enjoyed it. And we will see you next month, where we are actually going to be talking about knee pain. And that's bye from us.
Bye from now.